Good morning, everyone. My name is Yee Jim. I'm from Singapore. First of all, I'd like to thank the organizers for AAPCHS for the kind invitation. It's good to see so many old friends. My topic today is on how to use all diagnostic modalities to optimize surgical outcome for DORV. As we have heard over the past 2 days, DORV is an extremely heterogeneous group where great arteries arise predominantly from the right ventricle. And the surgical correction requires exact delineation of the VSD, its relation to great arteries, the presence or absence of any outflow obstruction, the ventricular and valvular anatomy, its associated defects. Hence, to optimize the surgical outcome, it requires a multimodal diagnostic approach that integrates imaging, functional assessment, and anatomical evaluation. The first modality is transthoracic echo. I actually feel this is the most important. Despite us discussing about 3D, about virtual, 2D echo is actually the most important because it is for resource-poor hospital. This is the best form that we can have. It's the most common, and not all DORVs require a CT scan or MRI. Hence, it is very important to have a good echocardiologist. It is also very important for the surgeon before the operation to sit down with the echocardiologist and go through the surgical anatomy. So echo is the first line for us. Determines mainly the location and relationship, looking at the coronal septum, as well as the presence and absence of any long conus, which can obstruct the pathway of the LV to the aorta repair. It also allows us to look for AV valve apparatus, whether is there a complete AVSD association as well. It also helps to look for straddling or overriding of the cords across the VSD. This is something that is best seen on echo and not the rest of the modalities. And this actually can complicate baffle repair. There's additional defects that echo can see, and we can also assess the ventricular function as well as size. Hence, the optimization tip is actually to use multiple views to define the spatial relationship of great arteries to the VSD, and sit down with the cardiologist to go through the anatomy before we go for surgery. The next modality that we can use is transesophageal echo. It guides us intraoperatively as well as post-operative assessment, confirms the surgical repair to make sure that we do not leave any patch leak, we do not leave any residual shunts, allows us to also assess the ventricular function post-repair. TTE or even TTE can best be used with 3D as well. Nowadays, they have a lot of tools as well for echo, be it 3D, explain. It helps us to visualize the VSD tunnel as well as valve function. And it's crucial in the operating room immediately pre-bypass to confirm the anatomy and the plan. Okay, cardiac MR is the next one. If echo do not show the anatomy that well, it allows us to detail the functional as well as anatomical assessment, provides a good 3D visualization for spatial relationship, and is invaluable for us to plan the baffle pathways. The other good thing about cardiac MR is actually it provides accurate measurement of left and right ventricular volumes, mainly for unbalanced ventricles, helps us for measurement, looks at ejection fraction as well as the mass. So especially good for whether we are deciding between two ventricle or single ventricle repair in borderline cases. So cardiac MR also allows us to measure our QPQS and to quantify valvular regurgitation. The other thing that's important with MR for whether is it single or biventricular repair is to look for any scar tissue, any EFE. These are things that help us to decide whether we want to go either one. Visualize for extracardiac vasculature as well. So the next one comes 3D modeling, which I think everyone gets a 3D model for this meeting. Allows us for pre-op simulation and planning, especially in complex anatomy. I actually feel that the 3D modeling, this point that is quite right is it eliminates misunderstanding and miscommunication between the surgeon and the images. Because sometimes the cardiologist may define things in a different way as you have defined. So 3D modeling actually allows us to then sit down together, go through the anatomy. The cardiologist can then correlate the model with what they see on 2D echo. And then for us, we can plan our surgery much better because a lot of misunderstanding can arise, especially with the definitions. So hence 3D model allows us to plan better, allows the surgical team also to rehearse the VSD tunneling, decide on how to cut the patch if you want. And also, like this meeting, allows hands-on surgical training for congenital heart surgeons. So this is how it looks like. This picture was taken from a Toronto paper. It looks at the VSD, the double outlet right ventricle, and how they do a patch. So I looked at the paper called Essential Modifiers of Double Outlet Right Ventricle, revisited with endocardial surface, published by the Toronto group. They have special interest with 3D. And with the MRI 3D modeling, they can look at the tricuspid valve attachments and where the VSD is in relation to the tricuspid valve, whether it's above the valve, is at the valve area, or is entirely complete AVSD type. It also allows us to look at the outlet septum primarily in relation to the VSD, whether it is fused to the left margin of the VSD, the right margin, or there's actually no outlet septum at all. So these are the things specifically that they look at when they do an MRI. So I find that sometimes we just order an MRI, but we don't exactly know what we want to look out during MRI. Is because some of my radiologists also just do an MRI without knowing what exactly to look at. So this list actually provides us a guide where we sit down with cardiologists, we sit down with radiologists, we know exactly what to look out for in a point form. Last thing that we do for DORV is actually a CT angiogram. It allows us to look at mainly the coronary anatomy. It's the most crucial. This is the CT's most crucial role. Maps out the cause of the coronary anatomy, especially if there's anomalies. It assesses the great vessel relationship as well as any MAPCAS. So cardiac catheterization is the last thing. It allows hemodynamic assessment, anatomical clarification as well. Mainly allows us to measure the pulmonary pressure as well as the resistance, the QPQS. And the last thing that is actually pretty good for cardiac catheterization is an occlusion test. In borderline left ventricle or right ventricular cases, you can occlude the double outlet ventricle to momentarily to see if it helps. My cardiologist hasn't done that, but I mean this is theoretical. It allows us to evaluate mainly whether you want a single or biventricular pathway. So intra-op, I mean how to optimize it. Intra-op, we mainly depend on TEE. Pre-bypass, it confirms the anatomy of the DORV. So a recheck for any missed details, especially for straddling valve. This may actually gives us, make us change the surgical plan. Post-bypass, when weaning off, it allows us to look for the baffle patency. Is there any pathway leak, any residual VSDs, any outflow obstruction after we reconstructed, ventricular function and valve function. I find this is very important because I had a personal experience when I was training. I was asked to close the DORV, and after I closed the DORV, before I come off bypass, the echocardiologist came in and said, the DORV is still there. so I realized I closed the wrong hole. So So that was very important because I would have tried to come off bypass, assuming that I did the right thing. I closed the right hole. So I redid the VSD patch, and the post-op echo was good. So to optimize surgical outcome, I actually feel intra-op TE is very important for us as a surgeon. It mainly helps us to audit our outcomes, audit what we have done as an independent assessor to make sure that we do the best for our patient. So if TE probes are suboptimal, sometimes we can do an epicardial probe, epicardial echo as well. Yeah. So this page summarizes the diagnostic tools available to us to look and what specifically to look out for with each tool, whether it's initial evaluation, detailed anatomy, functional assessment, and coronary evaluation. I think the slides I've given to the organizers, if you all want, you can ask for it. Yeah. So in conclusion, optimizing DORV repair is a multidisciplinary effort between cardiologists, radiologists, and surgeon. I don't think there's a single best test or diagnostic tool available for us. The modern approach actually involves a tailored combination of approaches. And I actually feel that nothing beats sitting down with the imager, the cardiologist or the radiologist to go through the images, especially the complex anatomy, clarify questions and doubts that you have in your mind. Because a lot of us surgeons, when we go in, we kind of reconstruct a three-dimensional image in our mind as well. So sitting down with them helps us to visualize how we want to approach and how we want to close the hole. So with that, I thank you.